Welcome to the Falcon Pathology Review Series for USMLE Step 1. This lecture will focus on disorders and hemodynamic dysfunction. We'll begin by considering the topics of thrombosis and embolism. This lecture will focus on disorders and hemodynamic dysfunction. We'll begin by considering the topics of thrombosis and embolism. In dealing with thrombosis, what one must simply remember is that normally blood must simply be maintained as a clot-free fluid that nonetheless has the ability to create a plug at its site of injury. Thrombosis merely refers to the intravascular coagulation of blood, and if it's present, one must consider that Virchow's triad has been encountered. That is, one has endothelial injury, stasis or turbulence of blood flow, and then a situation that predisposes the patient to a hypercoagulable state. Always remember, this hypercoagulable state may be due to an intrinsic defect in the coagulation cascade that predisposes the patient to the development of thrombosis. Some of the mutations in different genes that can lead to a patient having primary hypercoagulability include changes in factor V Leiden. Here the mutation results in the substitution of glutamine for an arginine at position 506 in this gene. What this mutation ends up doing is rendering activated factor V Leiden resistant to cleavage by protein C. Hence, one has the ability to develop thrombi, but not the ability to prevent thrombi from forming. Mutations within the prothrombin gene are also prone to patients developing primary hypercoagulability. There are also hereditary thrombophilias that are due to lack of antithrombotic proteins, including antithrombin 3, protein C, and protein S. With these hereditary thrombophilias, think about them in young women and look for a familial history within their surrounding relatives. This picture simply tries to demonstrate the balance that needs to occur within the endothelial wall of a vessel between prothrombotic and antithrombotic events. Note that where title should say favor thrombosis and inhibit thrombosis. There is, to the best of my knowledge, no condition within the development of thrombi known as thrombiosis. On the left-hand part of the slide simply demonstrates the development of a clot. Note the interaction between von Willebrand's factor and platelets held together by fibrinogen. Note that on the right hand of the slide we show the various factors that can inhibit thrombosis. This includes things such as active protein C, antithrombin 3, and then things such as TPA, which can lead to the fibrinolytic cascade, and things such as PGI, nitric oxide, and adenosine diphosphate, all of which can inhibit platelet aggregation and lead to clots not forming. Antiphospholipid antibody syndrome is worth mentioning at this point. This is a prothrombotic disorder with autoantibodies versus protein antigens complex to phospholipids. Clinically, how these patients will present is with recurrent venous and arterial thrombotic events. Often, if this is occurring in women, they will present with unexplained fetal loss. When their CBC is measured, you'll see that they have thrombocytopenia and may present due to the presence of these clots within the CNS with neurologic manifestations. Paradoxically, there's a prolonged PTT, yet you will still treat them with warfarin. These patients may also present with a false positive test for syphilis. The antigens in the test are bound to cardiolipin, and this disorder is sometimes associated with the systemic lupus erythematosus. Now, in terms of thrombi and where they can develop, remember that they can develop both within the arterial and venous systems. In arterial systems, they tend to develop in high flow areas, and the thrombi that develop here will tend to show what we call lines of Zahn. That is, when one looks at a cross-section of the thrombi, what one sees are gray areas, which consist of layers of platelets, interspersed with lighter areas, which are made up predominantly of fibrin. The major initiator of thrombi within the arterial system is considered to be atherosclerosis. Within the venous system, one should consider thrombi developing in low-flow areas, particularly low-flow areas within the distal lower extremities. There's an increased risk with stasis, hence see it in those patients who, for whatever reason, are on extended bed rest or are bedridden, increased risk with disseminated cancers, and then when one looks at the cross-sections of these clots, one will not see the sort of lines of Zahn that one associates with arterial thrombi. Now, the outcome of thrombotic events can be seen in this cartoon here. The thrombi that are present within a vein can either resolve completely without any other sequelae. They can be organized and incorporated into the wall of the vein. They may need to organize and be recanalated in order to allow blood to flow through, or they can embolize and go to other organ systems, including the lungs. Emboli is a term used to apply to objects passing and lodging in the circulation. Thromboemboli, those are the most common thromboembolus are the most common cause of emboli, and essentially refer to traveling thrombi. That is, thrombi that form elsewhere in the body and then travel to another organ system. The classic model for these, of course, is the pulmonary embolus. That is, an emboli that arises from a thrombi in the deep veins, generally in patients who are fulfill both the criteria of Virchow's triad, but also are placed under conditions that predispose them to the development of thrombi, such as being on bed rest following surgery. These patients, if they develop pulmonary emboli, can develop sudden cardiac death due to right heart failure from saddle emboli. Arterial emboli are generally due to mural thrombi from the heart or a large vessel. You will see these in patients who develop atrial fibrillation or who are status post myocardial infarction. They tend to arrest either in a lower extremity or, with more catastrophic events, tend to go to the brain and produce infarcts. Fat emboli you will see in patients who have undergone recent trauma, and they occur from fat being embolized from the bone marrow. Air emboli, think about these in divers, people who undergo rapid ascents in the water from one area of extremely high pressure to an area of a lower pressure. They have the development of nitrogen bubbles. This is what leads to what's commonly caused the bends. Also, you can see amniotic fluid emboli, which can also lead to the development of DIC in mothers who have just delivered. Now, one of the sequelae, perhaps the major and most serious sequelae of thrombotic and embolic events is, of course, the development of infarcts. Infarcts simply refer to areas of ischemic necrosis caused by occlusion of either the arterial or possibly the venous system. Again, these are generally due to thrombotic or embolic events, and they can be categorized as red or white infarcts. Red infarcts are generally due to venous occlusions, and you see an example in this section of lung here. You see it in loose tissue where blood is allowed to collect and tissues that have dual circulation. So again, the lung can be a primary candidate. Note, as you see here with this red infarct, that they can often be wedge-shaped. White infarcts generally occur in solid tissues that have a single blood supply. This here from this section of the liver shows a classic example of ischemic coagulative necrosis in an area of the liver where there was a thrombotic or embolic event that shut off the main blood supply to this area of the liver, leading to ischemic necrosis characterized by the dusky pale yellow color that you see in the picture here. We also must deal with the issue of shock. Shock can break down into a variety of subtypes, including cardiogenic, hypovolemic, and septic shock. As their names imply, they all have different causes. Cardiogenic shock is due, not surprisingly, to heart failure. These patients will present as hypotensive with a weak pulse and cool skin. Hypovolemic shock, as the name implies, is due to loss of volume, usually blood volume. Again, these patients will present similarly to patients with cardiogenic shock with hypotension, weak pulse, and cool skin. Septic shock is generally due to endotoxin release from gram-negative bacilli. Here what one will see is hypotension and weak pulse, but contrary to the sort of effects that one sees with cardiogenic or hypovolemic shock, these patients will present with warm skin due to peripheral vasodilation. The overall effect of shocks, however, can be the same on various organ systems. The kidney, remember, needs a very consistent supply of blood, and so if one develops shock, there's the possibility of acute tubular necrosis, which will eventually cause renal insufficiency. The brain also is an organ that is very demanding of keeping up a steady blood supply, and thus you can have areas of focal necrosis. The liver will show central lobular necrosis with hepatic insufficiency, the colon can undergo mucosal hemorrhage, and the lungs can develop edema, which may lead to respiratory compromise. And that ends this Falcon Pathology Review lecture for USMLE Step 1 on hemodynamics.